All right, listen up, listen up, listen up. Pay attention. Listen up. Good morning. Last day. Okay, I'm trying to get the test ready. So while I'm getting the test ready, I want y'all to watch this video. Okay, and I don't mean when I put the video on and walk out of here, you start talking through it. This is a very sentimental video. So let's respect this video. We got that? All right.
Hey, I wanted to just really hit on something. Dealing with pain.
Three, 4, 5, 6, 7, 8, 10.
I wanted to make sure sports was the reason I started training. It was to make sure man never put his hands on my mama. I told my mama, no pain will ever stop me from taking care of you and my brothers and sisters. That's why I started doing what I started doing. Sports was a byproduct of what people started to see. It was the behind the scenes that was driving me crazy. There's two sides of pain that I don't think a lot of people really understand. There's one side of pain that's the suffering and the discomfort side of pain. But then there's another side of pain that's called effort. It's called glory. It's called if you can find a way to push through pain, there's something greater on the other side of it. And if you never tap into it, it's because the first time you felt it, you backed off. The first time you felt that burn, the first time you felt that it's too much. We rationalize with ourselves to where we automatically stop. That's why most of us give up so much in life so quickly. That's why kids have a problem finishing things in today's time. As soon as they feel I'm small bit of discomfort, things ain't right. Oh, you know, I can't do it. But suppose I told you the greatest pain of my life is the reason I'm standing here today. I dare you to take a little pain. You don't know it. You're not gonna die because you feel a little pain. You ain't gonna die. At the end of pain is success. Pain is temporary. It may last for a minute, or an hour, or a day, or even a year. But eventually, it will subside. And something else will take its place. If I quit, however, it will last forever.
If I quit, it'll last forever.
On the other side of that pain, on the other side of that pain, on the other side of that pain, is your promise. At 10 years old, I picked up these deck of cards. And one day I counted them, and I found out there was 52 of them in the deck of cards. 52. And I took my greatest pain into in my business with the greatest achievement ever is the touchdown ball trophy. 52 cards. And ironically, my number ended up being 52. There's not a person on my team in 16 years that is good.
So you see that. All you guys see when you see the professional athletes is you see them making money and you see them getting this and you see them getting that, but there's a backstory. They had to do something. They had to overcome something to get to that point. And not many people are willing to do it. Just like he said, he wasn't the fastest, he wasn't the strongest, he wasn't the tallest. When he came out of college, the thing on him was he's too short to play linebacker, too slow to play linebacker. He heard that. He heard the words, you're too stupid, you're too small, you're too this. And instead of going, okay, I guess I had to find something else, what did he do? He told him, no, you full of crap. And that's a Hall of Famer. Do you understand that? One of the greatest linebackers that will ever play the game. Why? Not because of his height, not because of his speed, because of his heart. Do you understand that? Because of his effort. Same thing with you guys. You're on the same stage, believe it or not. Your career is just as glorified as his, if not more. You getting a college education just like he did. You're a professional just like he is. Do you understand that? And you're a part of a greater fraternity than him. There's way more registered nurses in this world than there is anything. So when you think I'm too tired, when you think I'm too whatever I'm too, you're not too. That's the path to get what you're trying to get to. When you're tired, when it hurts, when it's hard, you're on the right track. When it's easy, when it's relaxed, when it's comfortable, you ain't doing nothing extra. Are you listening to me? Okay, you've almost completed this journey. This message here is usually for the new students. This is what I play when I get my new students, usually in nursing school, to try to inspire them. This isn't for you, but I don't want you to forget this. And this is what, from this day on, you need to be teaching and telling other people. This type of stuff. Because now you're a registered nurse. Do you understand that? So you don't know what tired is. You don't know what hungry is. You don't know what suffering is. You don't know that anymore. Okay? You want to get right in that. You front line. Okay? All right. Let me print these other copies and we'll get started. How many people I got? Because I got to get these copies just right. There's 24 on the nose. 6, 7, 10, 11, 12, 13, 14, 8, 9, 1, 2, 3, 4, 25. Because are you staying?
Yes, sir.
So you want to participate in the exam, even though it doesn't count, it doesn't matter. Okay, 25. So I need 15 more. I have to do them 10 at a time because I'm on copy restriction. All right, don't be peeping. Okay. Print. So I get another 10 and then I got to do 5 more. That's crazy, ain't it? They got the teacher on copy restriction. Huh? Ray Lewis. Ray Lewis's motivational speech. Yeah, he was telling the story about how his mom was abused. It was him and his mom. And he saw it. And that motivated him to get stronger so nobody would ever hurt his mother. And then because he was getting stronger and getting better, that's how he got into sports. And he was explaining how he was. Oh, you know about it. Yeah. Hit between him and Brian Dawkins. You need to look up Brian Dawkins. Brian Dawkins is actually, Ray Lewis has a better backstory, but if you really want to get motivated, put on a Brian Dawkins video. Oh my God. He'll have you feeling like you got fire coming out of your blood vessels. Two. Count these for me. Make sure there's 10 there, please. Ronald, count that. Make sure there's 10. Please. Thank you. Thank you. There's 10 in there. Thank you. 10. Perfect. 5 more. So when you take this today, note there may be a question starting on one page and the answer's on the next page. I didn't have time to fix it. Okay, but you should be able to do it still. Okay. All right, hold on, get off that. All right, hold on. What do I need to do? How am I going to do that and do that and do that? We have this. Did I send the Sarah RN to you yet? Yes. I sent that? You sure? Because I don't even remember sending it. I sent that. All right, good. Then I don't need to project that because I don't want to show other things that I'm trying to go over. All right, so we was doing pharmacology yesterday. Hold on a minute. Figure out what is this. Is this which one's which? All right, that one, get rid of it. Okay, put this up here. All right, we'll do that in a second. All right, we went over those antibiotics. I want to go over them again, real quick. Penicillins. Again, what did I teach you yesterday about the penicillin? Highest incidence of what? Allergic reaction. Okay. Cephalosporins is the cross allergy, right? Huh? What? And it's also the largest antibiotic class. Did you know that? The cephalosporins. Okay. Some of the adverse effects of both of them, you could get a rash or GI upset from taking those antibiotics. We got that? Okay. And then what do we say is the go-to usually if they're allergic to either of the two? All right, let's put them cell phones in the text and all that. Okay. The Houston Texans got to go away for today. Okay. All right, tetracyclines, what did we say? Nobody, children less than 8 can't have them. What else? It's the most broad spectrum. They cause that photosensitivity, right? But most antibiotics do. What else? No dairy products because it inhibits the absorption. Very good. Come on. Then we got the macrolides. How do we know it's a macrolide? Because it has throw in it. What's the difference between aminoglycoside and a macrolide? Aminoglycoside has mycin, but it doesn't have what? A macrolide has what? There you go. See, that's quick and easy. All right, what do we need to know specifically about the macrolides? Well, that's where erythromycin falls into, so that's the alternative for that PCN or that cephalosporin allergy, right? It says adverse effects, they're kind of common: GI disturbance, dry skin, burning, pseudomembranous colitis. Let's look that up. A lot of antibiotics can cause pseudomembranous colitis. Let's look that up and see what that's going to cause. Pseudo, meaning false. Membranous. Colitis, meaning in the colon. Cause the colon to be swollen. Where does it say?
Inflammation of the colon that's caused by the bacterium C. diff.
Okay.
Common complication of antibiotic use.
Did you hear that? What is a common complication of antibiotic use? And you know what? You don't remember, I'll just say colitis. Just say colitis. What's a common cause of antibiotic use? You need to know that. Can that lead to what's called a toxic megacolon? Let's look this up. Is that associated with a toxic megacolon? And what is a toxic megacolon? Let's look this up. Mr. Decker might be just making stuff up. Let's look this up. What is a toxic megacolon? Did you hear that, guys? A severe complication of colitis is what? And you got to remember this one by full name. What is a severe complication of colitis? And what can happen during a toxic megacolon? Can you perforate the bowel? Bowel perforation. Are you listening to me? And let me teach you something else. Learn this, but don't hear this. Learn this. When it comes to antibiotics, not only are they killing the bad flora, but they're killing the good flora. You need that flora to synthesize vitamins. One of the main vitamins that it helps synthesize is vitamin K. You know what vitamin K helps with? So prolonged antibiotic use could lead to a what? A bleed. A bleed. Because you don't have that vitamin K because it's destroying that normal flora. Do we understand that? Did we look up toxic megacolon yet? What is toxic megacolon? Talk to me. We know it's a complication, but what do we got with that? Oh, wow. So that can lead to a bowel block? So they'd have to resection the bowel if they've got a toxic megacolon, right? And they may have to have a what then? A colostomy. We got that, nurses? We understand about that pseudomembranous colitis as an effect of taking what? Which could progress to a what? Which could cause the bowel to do what? Which could lead to peritonitis, which could lead to sepsis. We got that? You see how we tying all these foreigners in here? You've heard that. You've probably seen that a million times. Toxic megacolon and pseudomembranous colitis, and just kept it moving, didn't you? But now you actually understand what's going on down there, right? Guys, go into the NCLEX with this knowledge, man. It's going to get you out of jams. If you understand that when the colon gets inflamed, it's going to enlarge, and hence that's where the name comes from. And it's toxic because it's got all that waste in there, right? Okay? And that can disrupt peristalsis, leading to the bowel block. Too much pressure in that intestine can cause it to what? Burst. Time for the perforator. Huh? You ever heard that? Time for the perforator. Oh. All right. So macrolides. We remember erythromycin because that's our go-to, but there's also azithro and chlorithro. So pseudomembranous colitis. Okay. It says effective against most gram-positive bacteria and many gram species. It can also cause anemia. Your aminoglycosides, we know the two things that we worry about with these, don't we? Listen, what are the two things that we worry about with the aminoglycoside? That's right. Permanent hearing loss and kidney damage, right? Okay. You got to picture that little mouse. Remember the mouse? What cartoon was that on? With the mouse. Arriba. And he got big what? Ears. Okay. And if you know anything about mouses, they pee and poop a lot. Speedy Gonzales. Speedy Gonzales. Okay. Now, remember what I told you. They all end in mycin. There's an exception, and there's one that's popular that you need to know. Amikacin. Amikacin don't end in mycin, but it's an aminoglycoside. Do we understand that? Amikacin. Okay? So you name that mouse Amikacin. His name is what? And his last name is mycin. His first name is what? And his last name is what? But he never does what? He never throws things. Do you understand that? Because if he has throw in him, he ain't an aminoglycoside, is he? He's a what? Macrolide, and that's no lie. Okay? All right, fluoroquinolones cannot be given to people under what age? Cipro is a fluoroquinolone, right? Ciprofloxacin is a fluoroquinolone. Is ciprofloxacin a fluoroquinolone? Doesn't Cipro sound like a flower? Doesn't Cipro sound like a flower, like a fancy flower? Yeah, to me it does. And where do you buy flowers from? A florist. The fluoroquinolones. Huh? And if you sometimes they'll tell you to not pick the flowers, won't they? Will they tell you sometimes don't pick those nice flowers? So that would be levofloxacin. Leave it alone. Are you listening to? Come on, wakey, wakey, shaky, shaky. Did you drink your coffee this morning? Learn this class of antibiotics. Lock it down. That's not big boy stuff because they call it a fluoroquinolone. Because you buy what from the florist? Flowers. And we said we remember which one is the flower. Cipro. Sometimes they got honey in them. Take a sip. But for the most part, you're not allowed to pick them. You should what? Leave them alone. Levofloxacin. Do we understand that? Come on now. Look what it says. It's the preferred drug for treatment of uncomplicated UTIs. Okay? Most widely used drug in this class is Cipro, and it's also used to treat what terrorist agent? Anthrax. Anthrax. Okay? Can't take multivitamins or mineral supplements because they may reduce the absorption of the fluoroquinolones. Ooh, that's a big boy. Don't most people take vitamins and minerals every day? I just took mine today. I told you since I got that pill counter. I'm 5 days straight now. I have remembered to take my vitamins 5 days in a row. But if I was on a fluoroquinolone, can't take them vitamins and minerals. We got that? Is that a big time teaching? That's a big time teaching. If you're taking a fluoroquinolone, leave the vitamins alone. Okay? Now, this is the other big one. Fluoroquinolones can cause rupture of the Achilles tendon. They can cause your Achilles tendon to rupture. What can fluoroquinolones do? Rupture your Achilles tendon. So even a flower can kill you. Huh? Even a flower can kill you. Okay, especially if you're over 60 and on what other med that we learned yesterday? Something that pulls calcium out of the bones. It's really good for edema, but not only for short-term use. Oh, that would be corticosteroids, Mr. Decker. That'd be corticosteroids. What's really good for edema, but you can't take it for a long time? Corticosteroids. Okay. What age can't get these? What are the two main drugs in this class? Cipro and Levo. Cipro and Levo. Okay. What can you not take every morning with these? The minerals, right? What is the big issue? Rupture of the Achilles tendon. Got to remember that, man. You got to think about that. Then we got the sulfonamides. The big thing here right off the gate is what? Sulfur, right? If they're allergic to sulfur, guess what? Huh? Can they take it if they're allergic to sulfur? Look what it says here for this sulfonamide. It may cause formation of urinary crystals and fatal blood abnormalities may occur. It can cause urinary crystals. So is it important to teach your patient to increase their fluids on a sulfonamide to prevent that crystallization in the kidney? And then look, it goes into other antibiotics, and it mentions clindamycin. And guess what it says the most severe adverse reaction is? Pseudomembranous colitis. When it comes to antibiotics, I'd remember what? Pseudomembranous colitis. Pseudomembranous colitis. That sounds like pseudomembranous colitis. Huh? And that sounds like something you'd say when you got indigestion. Yeah. Come on, man. You could do pseudomembranous colitis. Yeah. All right. Red man syndrome. What is that?
from vancomycin.
It's just vancomycin.
It's administered through
It's Cipro as well. It's not just vancomycin. It's what? Now, pay attention. If you're driving in your van and you hit the brakes too fast while you're taking a sip, what's going to happen? You're going to wear it. So you remember, when it comes to doing things too fast, you got to remember driving in the van and taking a what? You don't want to be driving no faster than 60 miles an hour when you taking that sip. Because if you hit them brakes, guess what? It ain't going in your mouth. It's going on your face. Okay? Yeah, I'm going to come up with something. Some of my guys in here need that. Okay? Some of our guys in here need that. I need that. If I was going to take the NCLEX right now, I need a lot of that. Yeah. Don't matter how I get the job done, as long as I get the job done. Don't matter how I get the job done, as long as I what? That's it. How long do people usually take TB meds? 6, 9 months, year, 2 years. Why do they take the meds so long? Why do they take the meds so long? Is it to kill the mycobacterium? No. You could probably get treated for 2 to 3 months to eradicate the TB. They're taking it that long for all the other infections that they could acquire from having TB. That's for all the other infections, to prevent all the other infections. Okay? So the TB itself could be killed as early as how long? 2 to 3 months. Okay? But it's for all those other opportunistic infections that they could acquire from having TB. TB destroys that immune system. Okay? All right, let's move to the ear and the eye. If I could teach you something about the ear, if I could teach you something about the eye, let's start with the eye. We got to know what conjunctivitis is. That's highly tested. Conjunctivitis, let's look it up. AKA pink eye or stink eye. It's a bacterial infection, right? It's very contagious. What do you got to know about conjunctivitis? Okay? So if you got that, you shouldn't be going to work until you get that treatment, right? Hello? You shouldn't be sharing things in the house until you treat that, right? Shouldn't be using that old makeup stuff you be using while you're trying to treat that, should you? Can't be wearing contacts while you're trying to treat that, can you? You got to think about all that stuff. Stink eye, pink eye. Pink eye, stink eye. Okay? Look it up. What do we got? Conjunctivitis. What do we got?
Inflammation or infection of the outer membrane of the eyeball.
Okay, what does it say? Nursing interventions. Nursing interventions. Come on, we need them nursing interventions for that. What do the nursing interventions say for conjunctivitis? What's that? Hand washing. What else? Okay. What else? Separate towels and washcloths. I like that one a lot. Because we don't want to pass it on from person to person. Okay? What? Wash your pillowcase. That's probably where you got it. Somebody done put their butt on your pillowcase and passed gas. And then the makeup. What about the makeup products? Correct. What about the contacts? You can't wear them while you're getting treatment. Do you understand that? Okay. We got that? So conjunctivitis, is that what we just said? Okay. Do we know what nystagmus is? I'm thinking of things in the eye. I want to cover the eye. Rapid eye movement. What causes that? What causes look up nystagmus. Nystagmus. Look it up. A lot of things. But what does it mean? What's causing that? Why? Why do we have the rapidity of the eye? It's a what? Neurological vestibular disorder. Vestibular has to do with balance in the ears. Do we understand that? So we're not maintaining that equilibrium. That what cranial nerve is that? Vestibular cochlear. Cranial nerve number what? 8. That's dysfunction of that cranial nerve, right? Can't maintain that balance, right? Because you think about it. Listen, think simple. When you drinky, the alcohol, are you throwing off that balance? Yeah. When that cop pulls you over and goes, all right, follow my finger, what is he looking for? Nystagmus. That's what he's looking for, nystagmus, which indicates you don't have balance or equilibrium because you're inebriated. Do we understand that? Okay? Do we know what a strabismus is? Strabismus. What is a strabismus? It could be crossed, it could be out, it could be up, it could be down. You can't keep it in a fixed position. Do we understand that? Okay? Now, glaucoma. Got to know glaucoma. What is glaucoma? Glaucoma. Increased intraocular pressure in the eye. Why?
Too much aqueous humor.
Listen. How many of you guys wash dishes? How many of you guys wash dishes? I don't know about all that. I know a lot of women that don't. What do you put in the sink to stop the water? The strain. That's what you got in this lacrimal duct or this punja right here. This is where that aqueous humor drains out. Right in here. It goes this way across the eye. Bathes the eye, nourishes the eye, and it's supposed to drain out through here. Through this strainer, this filter. So if this thing gets partially clogged, then what condition do you have? No. Open-angled glaucoma. It's still what? It's just not draining like it should be. But it's still open. Do you understand that? This is the most common type. This is not the emergency variety. It can progress to the emergency variety if what happens? If it completely closed. That's closed angle glaucoma, and that is a medical emergency. It's just that simple. Do we understand that? It's just that simple. It's either open but not draining like it's supposed to be, or it's completely what? And what's that? It depends on the degree of the open. But with the closed, they'll lose the peripheral vision. Okay? But with the open, it depends. Depends on how bad it is. Do we understand that? We all have a little open. We all have a little open. Okay? That's why when you go get them eye exams, they check the pressure in the eye. Sometimes it could be a little elevated and they don't do nothing about it. Just depends on how bad it is. Do we understand that? What can that lead to untreated? Blindness. And within how long? 2 days. 2 days. You got closed angle glaucoma, and there's no way for that aqueous humor to drain out. That can put so much pressure on the optic nerve, it can lead to permanent blindness. Do you understand that? Closed angle glaucoma is a what? Medical emergency. We got that? What is the first symptom that they'll tell you that leads you to believe that they have that glaucoma? What is the first symptom that they'll report to you that lets you know? The loss of that peripheral vision. The loss of that peripheral vision. That tunnel vision she was talking about. Do we understand that? Okay. What about cataracts? Cataracts. Opacity of the lens, the cloudiness of the lens. What is the first thing they'll report to you if they have cataracts? The inability to distinguish colors. How do you know somebody possibly has cataracts? To extinguish colors. And then when you examine them, what you gonna see? That opacity. That opacity. You gonna see that what? They gonna report what? Inability to discriminate colors. Do we know what we need to know for the surgical procedures? If they have to have a cataract procedure or a glaucoma procedure, what do we need to teach them after the procedure? Nothing that increases pressure, right? Which side goes up when they sleep? The operative side goes up. Think about it. Which way will gravity go? Down. If this is the operative side, do I want fluid and things going down to where we just operated and there's edema and fluid already? So I want to put it up and let it drain, right? Everybody got that? What should they be wearing when they go to sleep? Eye patch. And then when they go outside, what should they be wearing? Sunglasses. Should they be bending at the waist? What is the number one nursing intervention prescription that you should see for this patient after these procedures? Listen to what I'm telling you. Listen to what I'm saying. What is the number one prescription, medication prescription that you should see for this patient after this procedure? Come on, think about it. If we don't want you to increase pressure, we don't want you to increase pressure. Stool softener. Don't forget about the stool softener. And I promise you on the test, they ain't going to give you no little guy going like that. I hope. They need a what? They need a what? Eye patch. They need a what? Sunglass. They need a what? They need a what? They need a what? We got that? Now, let's get into the visual problems. Presbyopia. What is presbyopia? Presbyopia. What is presbyopia?
Your vision going bad the older you get.
What type of visual loss? Presbyopia. Presbyopia. What do we got? Look it up. Look it up. What's that? Okay, but so it's not near vision. It's the loss of near vision. It's not nearsighted. They're not nearsighted. They're more what?
Farsighted.
Farsighted. And this is what they'll be trying to do. But they can't. That ain't going to do any good. Why? Because the arm ain't long enough to get outside of the near vision. That's what? 1 meter, which is how many feet? 3 to 4 feet. 3 to 4 feet is 1 meter. In order for them to be able to see it, their arm would have to be what? Longer than a meter. Anybody arms you know longer than a meter? Maybe Shaq. Shaq might have that. What time is it?
8:48.
Y'all need a break already? All right, 5 minutes. Ronald's like, please, Mr. Decker, turn that off. You ain't got no desk or nothing?
I gave him half the price.
Because I think there's an empty seat right there by Ronald. All right.
Girl, I was so embarrassed. Girl, I got out the car. I say, "Oh my goodness, look at my man." I done looked at the trunk and all that. Heather. Oh, that must be her room.
Mr. Decker, while I lost the tea, I left the tea at another part, and I taught my son last night how to throw and hit it with the ball
Good.
because I lost the tea.
Good.
Man, listen,
He looks like he already needs to be moving off that tee.
he only been on it for a couple months, but I'm trying to.
It's got good hand-eye coordination.
I'm trying to do it with my daughter too, because in order to play AU, you have to be able to do the mechanical throw. So I was like, well, I'll just teach you how to throw it. But it took him about 30 minutes, but he did it. Oh.
Today's a good day. Great day. Huh? Friday. Last day.
Yeah. A couple months back. I stopped wearing them for a while. I saw everyone wearing glitter Crocs.
Them New Balance comfortable. I've been thinking about switching. Giving some New Balance. I like the colors. But they comfortable, they light. Yeah.
Two pairs, like one like these and then one just regular tennis shoes.
Yeah.
Oh,
I've been thinking about it.
I have a hard time with New Balance because there's so many colors and styles.
I just gotta go to the store.
Yeah, it's like everyone's always like, no, you gotta get the 370s or the 450s.
Yeah, I don't know the numbers.
I'm
Yeah.
like,
No, I like my New Balances.
I gotta check them out.
I used to wear the front ones. I like those.
Yeah.
I used to wear Brooks or Asics a lot.
Asics is a good shoe. Yeah.
But then
I don't know about Brooks. I never.
Brooks are amazing, but they're expensive. But Asics are kind of expensive too. But what happened was they like redesigned their because they've got the different ones for how you step, and I know I step on the outside of my heels when I walk. And they redesigned the shoe, and it literally looks like a Skechers Shape Up now.
Yeah.
It's like this big, thick foam thing. It used to be these really nice, like gel.
Oh, I can't do the Skechers.
No, they look like Skechers.
Yeah, they look like old people shoes.
Yeah. Colors and they change the whole shoe.
I want to get away from Nikes because look, Nikes ain't comfortable no more like they used to be. They're not.
They feel cheaper and cheaper.
Yep.
Every time I get them.
Yep. Yep. I mean, now these are this model is super
Those
comfortable.
are the freeze, right?
Yeah, these I don't know the number, but these are super comfortable. But they don't, to me, look as good as some of my other
They say like
Nikes.
that's the male ER nurse shoe.
Oh, this is? Because they light. They light. Let me hit that restroom real quick and grab a soda. Tell her I got it. I got it. Study. When study's over, hey girl, hey guy, are you listening to me? That's the trick. That's the part of the studying that nobody understands. Everybody thinks that sitting behind a desk with a book open is studying, and it's not. If you got cell phone and you on it on that, if you got background noise going on, if you got people making you get up and then get back, you're not studying. You're wasting your time, is what you're doing. You got to be a student of your game, like him. He walking down the hallway looking at me and noticed my microphone. He's still about his job. He's thinking about his job. When you're at your job, you're thinking about your what? And now I'm not telling you got to be a robot. You can't talk to anybody, but you can't get so engaged in your conversations that they overtake what you just learned. Do you understand that? Or your brain's going to be like, what the hell, man? Which one do you want me to lay a memory track on? Hey girl, or that other stuff that you were just listening to, thinking about, hey girl. Are you listening to me? It's a way of life, guys. This is a way of life. This isn't a period. Okay, when it's time to class to start back up, then it don't work like that. I guarantee it don't work like that. I guarantee in your mind right now, it's not clear. You got things running through your mind, cars and other things running through your mind. The stress of life is running through your mind. What you got to do after school is running through your mind. And that's disrupting that memory pathway. And you can't afford. What do you think Mr. Decker thinking of on break? What do you think, Mr. I'm thinking about, oh, I got to tell them there's more than 30 questions on the test they're about to take. There's 31. I was thinking about, oh, I got to still go over macular degeneration. We just covered presbyopia. We just covered glaucoma, cataracts, conjunctivitis. But I still need to go over what? Macular degeneration to wrap it up. I'm thinking in my head, what are my next chess moves for the day? And I'm the one with the majority of the knowledge. Are you listening to me? I didn't say all the knowledge, I said the majority. Okay? So it's okay to say, hi, Ronald, how are you? But keep it moving. We're here to learn about what? Conjunctivitis, glaucoma, cataracts, presbyopia, strabismus, nystagmus. See, I just did a review of what I should know based on what we just talked about. And we could throw in the penicillins and the macrolides and the aminoglycosides and the tetracyclines and the fluoroquinolones. Right? Now let's get into this macular degeneration. Central vision loss. Which one's peripheral vision loss? Which one's farsightedness because of the result of loss of nearsightedness? Which one's the opacity of the lens? Look at these guys. That's what I'm talking about. That's what you call magic. That's magic. Now let's get into macular degeneration. And the most important thing I need to tell you is scan, scan, scan. If you got macular degeneration, how do you need to walk? Scan the room to compensate for that central vision loss, or you're going to walk into something. Are you listening to me? Central vision loss. Which one is that? Macular degeneration. Okay? There's two types of macular degeneration too, isn't there? A wet and a dry. A wet and a dry. Let's look that up. That has to do with the leaking of fluid. If it's not leaking, it's dry. If the fluid is leaking, it's wet. The blood vessels, whether they're leaking or not. What does it say? Wet and dry. What's the difference? Wet and dry. What's the difference?
Because the dry macular degeneration is the most common form, and you can progress slowly. While the wet is less common, but can cause more rapid and severe vision loss.
We got that? Because now the vessels are what? Leaking. They ain't leaking. And then we need to look up drusen. Look up drusen. D-R-U-S-S-E-N. Drusen. Correct. And that's associated with what condition? When you see drusen, what condition are they talking about? Macular degeneration. That's a sign of macular degeneration. What does it say for drusen? And it's associated with what condition? We got that? Retinal detachment. Let's look it up. Retinal detachment. Retinal detachment. What does it say for retinal detachment?
An emergency when part of the retina pulls away from the supportive tissue.
A retinal detachment is a what? Medical emergency. A retinal detachment is what?
Medical emergency.
What is the hallmark of a retinal detachment? Curtain closing. You said that? Curtain closing. Old Mel took the day off today. Huh? I got you. Retinal detachment. Is it painful or painless? See that? That's a problem then, right? Why is that a problem that it's painless? People don't usually seek treatment until they experience what? And pain is an indicator of advancement. Do you understand that? Whether you're talking about cancer or disease process, what is a pain an indicator of? Advancement. Retinal detachment. Do we know what the word inoculated means? Inoculation. 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 Inoculation like eyeballs. Look it up. Inoculation. The removal of the entire eye. So if the patient had an inoculation procedure, what is in that socket now? A prosthetic eye. They have a what? Prosthetic eye. And you have to care for that prosthetic eye. How do you care for that prosthetic eye? Nursing interventions. Nursing interventions. I don't know about right away, but they'll have one. Okay? Okay. Tell me the teaching for the
I
eyeball.
don't know the teaching, I just know how to do this.
All right, let's look up the nursing interventions for a patient with a prosthetic eye. Everybody got that? Mild soap and warm water. Avoid using what? Alcohol and brushes. Nothing abrasive, right? Are you listening to me? You got to know these things going in. Now, look up eye trauma nursing intervention. Eye trauma nursing intervention. What do you immediately do? If one eye has something impaled in it or it has trauma, what do? Wrap both eyes. Do you apply pressure to the eye for a bleed? Do you apply pressure to the eyeball if they're bleeding? And to the nose? Because that can lead to permanent blindness. Do you understand that? If you put too much pressure on that eye. Are you paying attention? Do you remove something that's impaled from the eye? Only if you can flush it, right? But nothing if it's embedded. You don't remove it. Wrap it, strap it, and send them on their way. ER. We got that? Six cardinal fields of gaze. Which 3 cranial nerves are you checking? 6 cardinal fields of gaze. 346. 346. 346. 346. And pay attention. Pay attention. When you're doing the 6 cardinal fields of gaze, you need to visually think about this. A center, and from that center, 1 point to the right, 1 point to the left, that up top, up bottom, up top, up bottom. Are you listening to me? So there's always going to be 3 in a row, like tic-tac-toe. There's always going to be what? And then there's always going to be an odd one in the middle. So 3 plus 1 is what? And then if you add the 2 sides, what do you got?
6.
3, 4, 6. 3, 4, 6. Are you listening to me? Tic-tac-toe. There's the odd one in the middle. Add it to the 3. What do you got? Add the 2 sides. What do you got? 3, 4, 6. Because this is the direction of movement that you're moving, right? Hello? Is it me you look? Oh. That's one of the best, greatest all-time songs. Lionel Richie. You ever heard of him? Name a better singer. You can't. Nobody's better. You could say as good as than Lionel Richie. Who can you say is better than Lionel Richie? You can't. And if you can, have them sing that song and let's see how they sound. All right. As good as. As good as. Have them sing that song and let's see who's better. About the same, okay? All right. What about females? Let's give some. Who's the best female singer of all time?
Mariah.
You think Whitney's better than Aretha Franklin? Not even close, okay? Maybe if she wouldn't have did what she did. Could have been Mariah if she wouldn't have did what she did. Mariah used to be the best. And then you got Celine Dion. What about her? That's one of the greatest vocal voices of all time.
Yeah, I like Celine.
See how they see, but you see the difference. When we're talking about the books, do you hear any of this? When we're talking about the books, yeah, but to make a point. When we're talking about the books, all right, I think we're good on the eye. As far as the A&P, let's do the ear quick, and then we'll get into the med stuff. With the ear, it's about the medias, the otitis media versus otitis externa. You got to know. With otitis media, we're going to use what? Antibiotics. Well, we don't normally use antibiotics with otitis externa. Do you understand that? Because of the misuse of antibiotics. So they're kind of trying to tell you, you don't want to use antibiotics unless you have to, so the severity of the infection is worse with media as opposed to externa. Do we understand that? And externa is usually just caused by what? Irritation. Water, swimmer's ear, right? But otitis media is caused usually by what? A bacterium. Do we understand that? So you can wear earplugs with the otitis externa, right? That's the swimmer's ear. To prevent that, right? Keep the ears what? Dry. But otitis media, you're going to need what? Antibiotics. Are you listening to me? Okay? So you need to know those conditions. What about Meniere's? Got to know Meniere's. What is Meniere's disease? It is an inner ear disorder that affects balance, and the primary hallmark symptoms are tinnitus, which is a ringing in the ears, and vertigo, which is a spinning sensation, which puts the patient at risk for what? Falls. What is the number one nursing intervention for a patient with Meniere's? What is the number one nursing intervention to prevent the flare-ups, the exacerbation of the condition? Decrease the sodium. The disorder is caused by accumulation of a fluid called endolymph in the inner ear. So which electrolyte attracts more fluid? Sodium. And you want to space out your fluids. Another teaching is to do what? Space out your fluids evenly throughout the day. We got that? Meniere's. What is the hallmark symptoms of Meniere's? Tinnitus and vertigo. What's the number one nursing intervention? Decrease sodium and space out the fluids. Okay? We also need to know what an acoustic neuroma is. an acoustic neuroma. What is an acoustic neuroma? What's that? Correct. A benign tumor on the vestibular cochlear nerve, which is AKA acoustic, which affects hearing and balance. But that's in the test plan. That's in the test plan, so that means that's on the table for a test question. Are you listening to me? It's on the test plan. Hearing. What does cranial nerve number 8 do? Hearing and balance. So if you have a benign tumor, that can interfere with that cranial nerve. And it can also affect cranial nerve number 5, which is trigeminal. Do you understand that? Okay? An acoustic neuroma. Now, everybody look up nursing interventions for a hearing aid. Look up nursing interventions for a hearing aid. Nursing interventions for a hearing aid. Don't put no alcohol. Don't submerge it in water. Open the door. Okay? Start it on the lowest frequency when you put it in the patient's ear and turn it up slowly. Come on. Come on. Now, understand the difference between a hearing aid and an implant. Understand the difference between a hearing aid and an implant. A hearing aid is for conductive hearing loss and enhances the sound that's supposed to be getting to the inner ear. An implant means you got damage in the inner ear. So it's taking the place of the inner ear. Do we understand that? With an implant. Okay? Everybody got that? Cochlear implant, correct. Because the inner ear is the cochlea and the vestibule. Okay?
It's fairly new, isn't it?
I'd be lying if I was trying. Okay? All right, so let's get into some of these meds. Let's get into some of these meds. The Houston Texans don't play today, right? Okay? Houston Texans don't play today. All right, let's see what we got. Where was that? Let's talk about meds that can cause glaucoma. Meds, medications. There are medications that can cause glaucoma. Some antihypertensives, some antihistamines, and some antidepressants. So when you given an antihypertensive med, an antihistamine, or an antidepressant, you need to be aware of what? And tell them they need to have what checked regularly. There you go. Now, some risk factors associated with glaucoma is high blood pressure, migraines, and normal aging, of course. Okay? All right, let's talk about the drugs that they use to treat glaucoma. The first one is called the prostaglandin analogs. The prostaglandin analogs are the preferred drugs because they have the longest duration and the fewest adverse effects. But they can turn the blue iris to a brown color. The prostaglandin analogs can do what to your iris? If you have a blue iris, it can turn it to brown. Okay, so that's where that latanoprost that we talked about yesterday. That's a prostaglandin analog. Did we learn about latanoprost yesterday? It'll put a tan on your blue eyes. Latanoprost will tan your iris. Are you listening to me? Other drugs that they can give you is bimatoprost, tafluprost, and travoprost. They all end in prost, as in prostaglandin. We got that? So if you're giving something that has prost in it, you got to worry if your eyes look like frost, which means blue, right? If it's got prost in it, what do you got to tell them? You can turn your old pretty blues what color? It also is going to sting, right? And cause redness. Most all eye drops do what? Sting and can cause what in the eye? Redness. Another class of drugs that they can use are beta blockers. Okay? Beta blockers decrease the production of aqueous humor. Also, alpha 2. Remember we learned about alpha 2? Ooh. Who can tell me what an alpha 2 adrenergic agonist would do? Turns off what? The sympathetic effect. It turns off the what? So instead of getting constriction, you're going to get what? Instead of things increasing, what are things going to do? Everybody got that? So we can use alpha 2 adrenergic agonists to decrease the production of aqueous humor because they shut things down. Do you understand that? They shut things down. So apraclonidine is an alpha 2 adrenergic agonist. And alphagon is used as an adjunct and combination. Okay? Most significant adverse effects of the alpha 2 adrenergic agonist is an allergic reaction. Everything else is common. Headache, drowsiness, dry mucous membranes, blurred vision, irritated eyeball. You can also use the cholinergic agonist. A cholinergic agonist. They activate the cholinergic receptors in the eyes and cause what to the pupil? What's the pupil going to do with a cholinergic agonist? What chemical are we talking about here? Acetylcholine. So what will a cholinergic agonist do to acetylcholine? See what I mean? We fumbled. We on the goal line, about to score. Nobody's behind us. We just broke away 80 yards. Nobody's behind us, but we got to celebrate. And what happens? Right before we crossed the goal line, we dropped the ball. You made an immaculate play look terrible. Guys, we're not moving today until we understand this. This is a simple concept. We don't refer to it as acetylcholine when we're talking about medications. How do we refer to it? And what part of the autonomic nervous system does the cholinergics or the acetylcholine represent? So right now, which part of your autonomic nervous system is working? So what is your pupils doing? Dilating or constricting? They are constricting. So if it's called a cholinergic agonist, the only other thing you need to know, base knowledge, is what is an agonist? What is an agonist? Is that going to promote it or block it? Correct. So a cholinergic agonist will do what to the acetylcholine? And as it increases the acetylcholine, what will it do to the pupil? Because you learned the other day, what happens if the pupils are dilated? The aqueous humor can't drain. Isn't that the problem with glaucoma? The aqueous humor can't drain. So what do you want to do to the pupils? So what can we do to make sure they're constricting? Promote which side of the autonomic nervous system? So in order to do that, what chemical do we have to increase? Acetylcholine. So what med represents acetylcholine? Cholinergic. Come on, guys. I'm going to put that on the 32. Now we up to 32. 32 questions now. That's how we going to do this today. That's how we going to do this today. Right now you got 31. But every time we miss something that we should know, we add another question. Another class of drugs that we can use is the carbonic anhydrase inhibitors. Didn't we talk about them yesterday? Yes, we did. And Mr. Decker taught you that a carbonic anhydrase inhibitor is a what? But we don't use it for that. It is a diuretic. Saved by the Bell by Mel. Saved by the Bell because of Mel. A carbonic anhydrase inhibitor is a what? But we don't use it for diuresis. We use it where? In the eye. So it gets rid of fluid. So it'll help get rid of the aqueous humor. Do we understand that? Okay. So dorzolamide, brinzolamide, they got that mide in them. Okay. They got that mide in them. Those are what kind of meds? Carbonic anhydrase inhibitors. You don't really get to pick your NCLEX date. Do you know that? You don't really get to pick your time. You know that? You kind of do, but you mostly don't. And especially because of the waiting list. You're going to call, they're going to give you a couple of options, and you're going to have to pick from that option. And then guess what? No matter how you feel, how tired you are, how hungry you are, you got to go to that test and perform. You got to turn it all the way up from the moment you walk in the door. You can't do this. You can't do this when it's time to take the NCLEX. Are you listening to me? You got to go in there with that mindset. Right now, we don't have that mindset because it's morning. We got to have that diurnal mindset. Do we understand that? Wake up every morning ready to what? How many of you wake up at the same time every day? I wake up at the same time every single day. Who sets up their outfit for the next day? You see that? You see that? How many people raising their hand? Not many, right? But who's always going to be on time? Even early. Who's always going to be ready to go from the start of the gun? Do you understand that? 99.9% of the time, Mr. Decker going to be in here ready to rock and roll. With the computer open, the lecture ready, the books open. 32. Did you watch that video this morning? Do you think that's real? Did that man need somebody to tell him what to do? No, he didn't. His situation, his circumstance was enough. You guys' situation and circumstance should be enough. Number one, you should have a chip on your shoulder. You were not a first-round draft pick. You will never be considered a first-round draft pick because you got to work and take care of kids and do all these other things. You can't totally focus on what? School. A lot of kids, as soon as they become an adult, their parents got money. What do? Send them away to school. They get to live in the dorm. All they got to do is focus on what? You don't get that option. You're not a first-round draft pick. So you should have a chip on your shoulder. You didn't have all those advantages that all those other students had. You don't have that advantage, unfortunately. So that should make you have a chip on your shoulder. Do you understand that? Something to prove. That's the only way you're going to separate yourself from the pack. An RN doesn't want to be in a pack. You're not a pack person. An RN is not a pack person. Do you understand that? An RN is a lone wolf. Every now and then they'll congregate with the other wolves to get something done. But an RN is a lone wolf. Do you understand that? Capable of taking on things by themselves. But in order to do that, you got to have the properties. You got to have the characteristics. You can't fall back. Do you understand that? Don't ever fall back. If you're going to fall, which way should you fall? Forward. Never backwards. In order to do that, you've got to do things. You got to do things and you got to do things. Does everybody understand that? Let's make this Friday count. This is the last time you'll ever see me except graduation. This is the last time you'll ever see your comrades except graduation, unless your friends outside. But for the most part, you won't even see each other that much. You won't. Everybody says, we all said, oh, girl, we'll stay in touch and all that, but then life will start pulling you apart. For the most part. There are exceptions. But for the most part, most of y'all won't see each other again. Let this count. Make this count. You're going to be out there, you got your little group chat? Got your little group chat? So everybody going to be keeping it out. Girl, when you test. And they're going to be like, what'd you do? How'd you do? Don't you want to say, I passed, man? What you talking about? That's right. Let's hit it hard. Less than 3 weeks, you're going to be a registered nurse. 4 weeks. Hey. You're going to be a registered nurse. 4 weeks away. Didn't this week go fast? Watch and see what happens when you get out of school, how fast that time goes. You're going to wake up one morning and it's time to go to the exam. You're going to wake up one morning, what time is it? Time to go to the exam. Okay? And you got to have the same mindset that you do today when you ain't got to take the exam. You can't change. Ain't no time for that. Wipe it off. I wish sometimes they would let me be honest to people. I wish sometimes they would let me be honest to my students. I can't be but so honest to y'all. I can't, unfortunately. The rules don't allow it. Sometimes I really want to honestly tell a student who's frustrated or upset or this or that you don't have time for that. But I can't. But you ain't got time for that. All that's doing is prolonging it. Do you understand that? It ain't going to make it no better. You still going to have to face the music. If it ain't from me, it's going to be from somebody else. And guess what? That somebody else might not even care. They're going to just let you sit in there with your feelings and, okay, have a nice day, and not teach you nothing. Okay? Take this serious. Carbonic anhydrase inhibitors are what? But we don't use them for diuretics. We use them to treat what? Glaucoma. Very good. Okay? You guys know about the osmotic diuretic, right? Osmotic diuretic. We use that for glaucoma too. Did you know that? Hello? What kind of diuretic do we use for the eyes? Now, I want you to think. I want you to really think about it. How does that osmotic diuretic work? How does it work? How's it going to work? Isosorbide. How's it going to work? Mannitol. How's it going to work? Isosorbide. How's it going to work? It's going to pull the fluid out. Where's it pulling it to, though? Where's it pulling it to? Correct. The blood vessels. So what happens if you pull too much too fast? Correct. When we're giving an osmotic diuretic, we need to wash what? Where's the first place you're going to see circulatory overload? No. Where's the first place? And where's the first place the heart pumps the blood? So any volume disturbance, when you're talking about overload, where's the first place you're going to see it take effect? Are you listening to me? Did we talk about conjunctivitis? If you see eyes If you see the eyes, they're testing you on the eyes. You see MY. What are they doing to the pupil? If you see MI, what are they doing to the pupil? Does everybody, 3 people? If you see MY, what are they doing to the pupil? If you see MI, what did they just do to the pupil? You understand the Y is wide. The I is what? Narrow. That's how you remember that. You could see that. You could see that. You got to know that. That's a free money. Is that free money? What is a cycloplegic? Cycloplegic. What is a cycloplegic? We should know that. What does that sound like with the back ending plegic? Plegic. Plegic. Paralyzed, right? So that's a med that paralyzes those muscles in the eye. You get it every time you go to the eye doctor. What's the name of the med? Atropine. What's the name of the med? Atropine is a what? Cycloplegic also. Atropine is a what in the eye? A cycloplegic dilates the pupil and paralyzes the ciliary muscle and prevents the lens from moving while they're trying to assess your eyeball. Mm-hmm. We got that? Or we ain't got that? Do we got that? Let's talk about this external otitis again. What is the nickname for that? Swimmers here. What it usually cause? What's the cause? Water. Water. Now, otitis media, that's usually the result of what? And where do you usually get the infection from? Smoking or the respiratory tract, period. An upper respiratory tract infection can transfer to the what? To the ear. Okay, what's the risk? What's the risk of untreated otitis media? Huh? Hearing loss? Yeah, hearing loss, but what's the danger, the complication? Close. Mastoiditis. It gets into the bone. That's what you need to know. If you don't treat that bacterial infection in the middle ear, where can it go next? The mastoid bone. Do we understand that? And cause what? Mastoiditis. Is that considered It's the mastoid bone. It is. It could be. It could be. It could be. Because it does have to do with a bone, but it's specific to the mastoid bone. Okay. No, because it's specific to a certain bone. Okay. Osteomyelitis, what you're talking about, you could use that term for the femur, but you can't use that term for the mastoid because you could get various infections on the femur, whereas if it's the mastoid, it's usually because of the ear. Untreated ear infection gets into that bone. Whereas if you had infection in your bloodstream, it's not necessarily going to make it all the way up to you. It could, but it's not necessarily going to make it all the way up to your jawbone. It's going to affect other things first. So technically, could you get away with saying that's a form of osteomyelitis? Yeah, because it's inflammation of the bone. Okay? But it's called mastoiditis because it's specific to the mastoid bone. We got that? There's a lot of that. There's a lot of that. I do that all day. I'm still stuck on the paracentesis for the peritoneum. The peritoneum, not the peritoneum, the peritoneum. Whatever. I don't understand the correlation. But yeah, you're going to see a lot of that where it don't make sense. It doesn't correlate. Why not just call it all osteomyelitis if it's affecting bone? Okay? It says it's frequently the result of chronic or reoccurring bacterial otitis media. The infection moves into the bone and the surrounding structures of the middle ear. It requires aggressive antibiotic therapy with very strong antibiotics, such as gentamicin or penicillin, ticaracillin. Okay? Do we know what meclizine is? Meclizine. Meclizine. What is that? Meclizine. We never heard of that? Motion sickness. Yeah. Motion sickness. Okay, so that's kind of like scopolamine, right? Meclizine, scopolamine. Otitis media is treated with systemic antibiotics. Children, they use amoxicillin. What is cerumen? All right. Let's do some prioritization questions real quick. Cancer. You are caring for a patient with esophageal cancer. Which of the following tasks could be delegated to a UAP? Initiating daily weigh-ins? Because they got initiated, right? Initial first. Who always does initial first? It's part of the assessment, right? Facilitating the expression of grief or anxiety. Observing the patient's response to feedings. Assisting the patient with oral hygiene. A 56-year-old patient comes to the walk-in clinic reporting scant, what does scant mean? Rectal bleeding and intermittent diarrhea and constipation for the past several months. There is a history of polyps and a family history of colorectal cancer. While you are trying to teach about colonoscopy, the patient becomes angry and threatens to leave. What is the priority diagnosis? Patient gets angry, threatens to leave. You heard some news that he didn't want to hear. What's the priority? A nursing diagnosis, guys. Do I have to give you the choices? I shouldn't. Diarrhea, constipation related to altered bowel patterns. Is that a correct priority nursing? No. Who's the priority right now? And the way the patient what? Feels. And we just produced a lot of what on that patient? Say it ain't so. What did you say? So what is the term that we use for stress? Anxiety. So what's the priority nursing diagnosis for this patient? Anxiety. Anxiety related to unknown outcomes and perceived threats to body image. That's the priority. Do you understand that? What is the patient upset about? They don't like to hear the news that they just received. What is that going to cause in the patient? So what's the priority to address first? We got that? What patient is at greatest risk? Did I do this one already? I thought I did, but I'll do it again. Which patient is greatest risk for pancreatic cancer? An elderly white woman who has pancreatitis, a young African American with type 1 diabetes, a young white obese woman with a gallbladder disease, or an elderly African American who smokes. Correct. I did talk about it. For a patient who is experiencing side effects of radiation therapy, which task would be the most appropriate to delegate to the UAP? Helping the patient to identify patterns of fatigue, recommending participation in a walking program, reporting the amount and type of food consumed from the tray, checking the skin for redness and irritation after the treatment. For a patient receiving the chemotherapeutic drug vincristine, for the patient receiving the chemotherapeutic drug vincristine, which side effects should be reported to the physician? You're taking a med for what? Cancer. What's the name of the med? Vincristine. And it wants to know what side effects should be reported. Fatigue, nausea and vomiting, anorexia, or paresthesias. Paresthesias indicate what? Come on, back your answer up. What does paresthesias indicate? Look it up. If you don't want to look it up. Okay? Look it up. Get in the zone, auto zone. Get in the zone, auto zone. Look it up. Auto zone. Take 5. It does not take 5 minutes, by the way. That's bull crap. To take 5. Yeah, it don't take no 5 minutes. Yeah, and they tearing it up. Yeah. And they're tearing it up, costing you more money. Oh, we found something. No, you caused something. Did we look it up? It says paresthesia is a side effect associated with some chemotherapeutic drugs, such as vincristine. The physician can modify the dosage or discontinue the drug. Fatigue, nausea, vomiting, and anorexia are common side effects of many chemotherapy meds. Okay, but paresthesias, if you're experiencing paresthesias, what effect is that going to have on you? What effect is that going to have on you? Is that gonna be uncomfortable? Number one. Number two, is that going to interfere with natural nerve impulse and ability? Number three, could that put you at risk for a fall? Are you listening to me? Do we want the nervous system destroyed here? Then we want to address them paresthesias, right? I get paresthesias sometimes. You guys ever got paresthesia? You know how it feels? Sometimes the paresthesia is so bad, it's like a toothache in your body. Do you understand that? It can be so severe. It's like having a toothache in your arm. It won't go away. It won't stop. And then there are other times I can't feel things or I drop things because of those paresthesias. I think I got it, but I don't got it. You understand that? I think I got it when I go to grab it, but I don't have it. And I end up what? So we don't want paresthesias, do we? But we can't prevent some side effects. So some side effects like fatigue, that goes along with the game plan, right? Nausea and vomiting, that goes along with the game plan. Anorexia, right? When do we get concerned about nausea and vomiting? When we lose too many electrolytes and losing too much fluid, right? And the metabolic state changes. But we can't avoid it right off the gate. We can try to treat the symptoms and prevent it, but that's common, right? Whenever the body doesn't want something inside of it, what does it do? Shuts down the GI tract and wants to give it back. We got that? Here's a good one. This one's a good one. For a patient who's receiving chemotherapy, which laboratory result is of particular importance? White blood cell count. Because now they're at risk for what? And then you can make an argument. Say that again? Who said CBC? Because you want to check all of them, right? Because chemotherapy drugs can depress all them cells, right? Red blood cell, white blood cell, and platelet. What do we call that? What? Yeah, but what do we call the suppression? Huh? What do we call that type of suppression? Milo. Oh, Milo. Is that Milo suppression? Are they nice and call it bone marrow suppression? What type of suppression is that of growth? Hold up, let's talk about this. What a type of suppression of growth is that referred to as? What is the term for growth in the body? Plasia. Plasia means what? So if something's suppressing the growth, how do we refer to that as? Put an A in front of it. What do you call it? Aplastic. IC pertaining to plasia, aplastic. And that's where that aplastic anemia stems from, right? But whenever you hear aplastic, it's suppressing what? Growth of something. Do we understand that? Aplastic. What is it doing? Excellent. Another term for growth is trophy. Trophy refers to growth as well. So when a muscle doesn't grow because we didn't use it, it's called what? Atrophy. When it grows excessively, then we call it what? Hypertrophy. You see that? Free money, man. Free money. You got to get them free money things. Know all them terms. Roll up in there. Roll up in there with the lingo. Yeah, got to have that lingo. All right, let's work on something else. What happened? Can't turn. We were waiting on you.
You were?
No, I'm just playing.
Listen, y'all. I went to 3 stores in the morning because the first one had none.
See, Ronald, I told you he'd get you a rose.
I was like, I cannot give these roses to people. And so they're not the best ones, but.
Oh,
Okay, so I
wow.
got different colors. So I'll start with you. One of these. Sir, I'm not going to discriminate with you like one. No, I'm going to do it. Same color.
Look how nice that is there. Huh? No.
I was driving and I thought, but how did I keep them alive to the end of the day? Because how small these pieces.
This is a red rose. You understand that? When I show up. You get in there and get your rose. Change in there giving out roses. Go get you a rose. One of your ID anyway.
favorite. Yes. Mr. Decker, would you like one?
Oh, no, thank you.
Okay. All right, everyone has one? Everyone. You're welcome. Remember me when I call you and I need a response.
That's very nice of you, Shay. Thank you. You're welcome. See that? They be thinking about y'all.
Yeah, but I'll give it to Mr. Trainer. I did tell him that.
That smells good. All right, hold on a minute. Listen. Remind me at lunchtime or whenever I walk out of here to take this off, if you can remember, okay? All right, come on, let's get back in there. Come on, let's get back to it now. Come on. Let's not lose it. Let's talk about something fun. Maybe you'll want to pay attention to this. I figured I'll change it up a little bit. Let's talk about CPR. If they have a pulse but they're not breathing, then what do we provide? If they have a pulse but they're not breathing, then what do we provide? Breaths. Okay? Do you understand that? They have a pulse but they're not breathing, then you just apply what? Are we listening? If it's an infant, how many breaths in a minute? 20. Who said 2? Put a 0 on the back of that. Please. I can see that now. Hold on a minute. Ain't been 30 seconds yet. If it's an infant, how many breaths? If it's a child, how many breaths? 15. If it's an adult, how many breaths? 12. What's the normal respiratory rate? So you want the minimum, 12. We got that? Say it again, Decker. If they got a pulse, but they're not breathing, how many breaths for an infant? How many for a child? How many for an adult? We got that? Okay. If the airway is included, what do? Abdominal thrust on an adult, but what about on a young child? Back blows, alternating, right? Everybody got that? Flip them. How long, no longer than how long should you be assessing that carotid artery? When you're doing CPR, how far are the compressions in depth for an adult? Okay, but what does that equate to? 1.5 to 2 inches. 1.5 to 2 inches. For an infant, half to an inch, half to an inch, half to an inch, half to an inch. How many compressions in a minute for an adult? How many compressions a minute do you want to get in an adult? Aren't all of you guys CPR certified? Now, how many compressions in a minute do you want to get in for an adult? 100. 100. 30. 100. How many compressions do you want to get in a minute? Who has a heart rate of 30? 30, you don't do 30 compressions in a minute. That's a cycle. Do you understand that? 30 per cycle. But how many do you do in a minute? Listen, I'm not even playing around on this one. This is serious business. How many compressions do you want to do in a minute? Are you listening to me? What is the 30 for? 30 at a time, and then you give them what after the 30? 2 breaths. But how many do you want to get in a minute? Listen, don't play around with this one. This ain't funny. How many compressions? Chest compression. Do you know how successful CPR is by itself? 2%. 2%. So you better make sure you're doing it right. With no other support, CPR by itself is only what? 2% effective. How many compressions you want to get in that infant? 100. What's more important for an infant, the compressions or the respirations? Correct. Because most of the time with an infant, it's not going to be a heart problem, it's going to be a respiratory problem. Do you understand that? Everybody got that? If there's one rescuer with a child, what do we use for the reps? How many compressions? If there's one rescuer, 15 to 2. Okay? How many complete cycles do you do on an adult? Before you reassess, how many cycles do you do? 4. 4 cycles. How many cycles do you do before you reassess an infant? 20. 20. How many cycles do you do on an infant? When do you stop CPR? When they respond, that's one way. What else? If the person providing the CPR can no longer continue, meaning you're exhausted. If you are exhausted, they don't want you to do ineffective compressions. Do you understand that? So if you're not able to do the compressions properly, that's not your fault because you wore yourself out. Do you understand that? Okay? It says the reasons to stop CPR is when a victim responds, someone takes over for you, EMS arrives, or if the rescuer is unable to continue. Okay? What is the hallmark of croup? A bark-like cough, and we call that inspiratory what? Stridor. They're also going to have dyspnea. Okay? Can you look at the lips of a child to see if they have cyanosis or not? No. Because cyanosis around the lips may be normal. You need to look inside the mouth. Okay? What do you teach the parents to do someone who's having an exacerbation from croup? What do you teach them to do at home? Hot, steamy bathroom. If that don't work, then what? At least take them outside. Okay? At least get them outside. What is a croup-at or a mist tent? A croup-at or a mist tent? What is that? Okay. Okay. So what do you know about that? When they're wearing that, what's going to happen? They're going to get the clothes wet. Why is that a problem? Infection. So they need to do what frequently? Change their clothes frequently. When you're using the croup tent or the mist tent, you need to keep that child dry because that water enhances the risk of what? What is the treatment for croup? What is the treatment? What else? What else? What about hydration? Hydration is crucial for croup. Hydration is crucial for croup. What about antipyretics? Are they going to have a high elevated temperature? Come on, guys. What am I talking to myself? What is crucial for the treatment of croup? What else? Antipyretics. Okay. Can you give them aspirin for that temperature? What should you give them? What can you do to enhance their respiratory effort? Huh? Prop them on a pillow. This will drop the diaphragm and enhance respiration. Prop them up with a what? To drop the what? The most crucial vital sign is what? The most crucial vital sign for a child with croup is what? Heart rate. Because heart rate means what? Increased heart rate means what? Hypoxia. What's the most crucial vital sign for a patient with croup? When the heart rate elevates, it means what? Do we understand that? What's the most crucial vital sign for a patient with croup? What's the most crucial vital sign for any respiratory condition? Because heart rate is an indicator of what? What's the difference between angina and an MI? What is the difference between angina and an MI? 20 minutes. What is the difference between angina and an MI? 20 minutes. What's the difference between an angina and an MI? Think about it. What do you do for someone that has angina? Times what? Every what? How much time is going to elapse before you realize that that's not effective? Now you suspect what? What are the two diagnostic tests for an MI? EKG. I said two. Troponins. EKG and troponins. Would you do an EKG and troponins if that angina lasted longer than how many minutes? We got that? And that's if you're giving them nitro, right? If you ain't giving them nitro, if they don't have nitro, then you might not want to wait 20 minutes. Do we understand that? Instead, you would do what? Immediately do an EKG and check the troponins. What is the pain usually with an MI? Huh? Crushing, prolonged, and it radiates to the jaw and the neck. The patient will be short of breath, may complain of indigestion or gastric discomfort. If somebody comes in with indigestion or gastric discomfort of unknown origin, what do you keep in the back of your head? Possible what? The white blood cell count increases 2 days to 1 week after an MI. The white blood cell count increases as early as 2 days to 1 week after an MI. The ESR will elevate. The CPK-MB will elevate first in the first 12 to 24 hours. The CK-MB. The LDH responds 48 to 72 hours and remains elevated for 5 to 7 days. And then the SGOT. The SGOT increases later. So after 3 nitros, 5 minutes apart, they have no relief. What do we suspect? Oxygen is applied. You need to control the pain. Thrombolytic therapy must be started within how many hours? 6. When it comes to an MI, how many hours? Streptokinase or TPA. What is a contraindication to a thrombolytic? History of any kind of bleeding disorder or hypertension. What is a contraindication to a thrombolytic? You'll place them immediately on bed rest. This will decrease the pain, the anxiety, and the oxygen demand, and also the workload of the heart. You're going to give them beta blockers to reduce the heart rate and irritability, and morphine sulfate to reduce the preload and the afterload. It will also help with anxiety and chest pain. Also, lidocaine, verapamil, or atropine are used for any dysrhythmias. Anticoagulants are started. You have to monitor the vitals and the INO, and you're going to need to infuse 2,000 cc's a day of fluid, and you have to watch out for congestive heart failure. Teach them to stop smoking, reduce stress, reduce caffeine, reduce fat and cholesterol, and exercise, and let them know that healing can take up to 6 weeks after an MI. How do we assess for a cardiac rhythm disturbance? A cardiac rhythm disturbance. How do we assess for that? First thing we want to know is it syncope or dizziness? The first symptom that we want to ask them about, are they experiencing syncope or dizziness? Look up syncope. Look up syncope. What is syncope? What is it? A brief loss of consciousness and muscle tone caused by a temporary reduction to blood to the brain. That's syncope. Now look up dizziness. A common symptom. Dizziness is a what? Syncope is not a common symptom. Do we understand that? It's an accurate report of lack of oxygen to where? Does everybody understand that? Ectopic beats or slow heartbeats can cause dizziness. Either one of them, they could fall. Do we understand that? When do we get concerned about PVCs? More than 3. Okay? More than 3 premature ventricular contractions, we're worried. And usually PVCs convert to what? VTAC. PVCs more than 3. What are we going to see next? And VTAC advances to what? VFib. And VFib advances to what? Does everybody understand that? When do we worry about the PVC? When we see more than 3. What is a palpitation? The patient is reporting palpitations. What does that mean? A premature beat or an extra beat. What is a palpitation? Okay? It produces abnormal sounds. A premature beat or an extra beat. You're not going to hear that loved up. There's going to be an extra sound or an abnormal sound. What is a murmur? What is a murmur? It could be the valve. It indicates turbulent blood flow. Turbulent blood flow. Look up turbulent blood flow. What is turbulent blood flow? Learn what a murmur is instead of the Houston Texans. Look up a murmur. What does turbulent blood flow mean? Turbulent blood flow. What does that mean? What do we got over here on the left side? What is turbulent blood flow? Come on, somebody tell me what turbulent blood flow is so everybody can hear it. What you got?
Turbulent blood flow describes a chaotic, disorganized flow pattern of blood vessels characterized by eddy currents and fluctuations. Unlike laminar flow, where blood moves smoothly in parallel layers, turbulent flow can occur due to factors like high flow rates, vessel obstructions, or structural irregularities like branch points or cracks.
That sounds like a lot, don't it? Have you ever stuck a needle into a bottle? Have you ever stuck a needle into a bottle and tried to pull without injecting any air in it? It's very resistant, isn't it? Because of the turbulence. You push the air into the bottle to stabilize the turbulence. Same thing with blood flow. When there's something preventing its flow, either the viscosity or the velocity or a valve that's defected, it's going to interfere with its turbosity. Do you understand that? Making it harder to move. So instead, it usually goes back in the opposite direction. Fluid chooses the path of least resistance. Turbulent blood flow is backflow of blood or resistance in trying to exit the heart, like as in aortic stenosis, where the aortic valve does not open all the way. This causes turbulence to the blood flow. So not all the blood's going to make it through. It's going to go back and cause regurgitation. Do we understand that? Okay? What can cause a PVC? Could. What else? What about emotions and fatigue? Emotions, fatigue, caffeine, tobacco causes the heart to race. What is the hallmark of a head injury, a skull fracture? Bruising, raccoon eyes, and battle sign, right? Bruising around the eyes, raccoon eyes, and what? What is a concussion? What is a concussion?
Damage the brain or bruise the brain or
Bruising of the brain that causes temporary loss of memory and a decreased level of consciousness. It's going to cause a temporary loss of what?
memory.
And what is contra croup? Contra croup.
Two sides.
So it's when the brain moves from front to back. Okay? And what kind of damage does this cause? Front to back, so the back part gets damaged. So what is this going to cause? What lobe of the brain are we talking about back here? That's occipital. What is occipital control? Vision. If they suffer damage to the back of the brain, what is that going to affect? What is a contusion? A brain contusion. That's a bruise. Okay? And that can lead to what? What can a brain contusion lead to? Coma. A coma. Complete loss of consciousness. Do we know the difference between decorticate and decelerate posturing? Decorticate is what? Flexion, internal rotation. What is decelerate? Extension, external rotation. What is decorticate?
Internal rotation.
Flexion, internal rotation. What is decelerate? What is a laceration? Huh? It's a penetration. It's a penetration that results in a bleed. It can either be visible or hidden. A laceration could be either what? But it indicates what? What is an epidural hematoma? An epidural hematoma. What is an epidural hematoma? Yeah. And outside the what? Okay. So this space here, we've got a skull bone right here, right? Skull bone right here. And then this is the dura, which is the first part of the meninges. So if it's an epidural hematoma, it's in this space right here. So it has no way to get out because what? And it has no way to drain because what? It's outside the meninges. Do we understand that? It has no way to drain. Where's it going to go? It has nowhere to go. So this one here is serious because it has nowhere to go. If it's subdural, then at least it's in the meninges and it has a chance to be facilitated and drained out. But if it's epidural, it has nowhere to go. Are you listening to me? Houston Texans don't play today. Okay? And that includes they play the computers too. Houston Texans ain't supposed to be playing today. Okay. So if a patient has an epidural hematoma, what are they at risk for and how long?
Well, pressure on the brain. Could cause an increased air pressure.
Correct. So they want you to know there's going to be these symptoms that they may display for the first 24 hours. Everybody look up ipsilateral, pupillary dilation. Ipsilateral refers to what? One side. Okay, one side. It'll be on the same side as the damage. Ipsilateral, same side as the damage. Pupillary dilation. So one pupil will be what? Larger than the other. What do we call that when one pupil is larger than the other? Anisocoria. Look up anisocoria. They'll also have short periods of unconsciousness and contralateral weakness. What does contra mean? If ipsi is the same side, then contra is the what? Say it again, Decker. If they have an epidural hematoma, what are some of the symptoms that they could experience in the first 24 hours? Ipsilateral pupillary dilation, where one pupil is larger than the other, but it'll be on the same side as the injury. And they could have contralateral weakness, which is what? The opposite side. Do we understand that? For how long? So any head injury, we want to monitor them for at least how long? And try to prevent them from doing what? Sleeping as long as possible. You want to keep them awake. Do you understand that? So you can monitor for the ipsilateral pupillary dilation and the contralateral weakness. Everybody got that? Now the subdural usually involves the veins. Okay, it'll cause a decreased level of consciousness, also the ipsilateral pupillary dilation and the contralateral weakness. So the same similar symptoms. But again, the biggest difference between the epidura, meaning outside the dura, and the subdural, meaning under the dura, is the subdural at least has a chance to what?
We have audio now. All right, well, here's his microphone.
Ain't run out. Okay? Ain't run out.
He said you said microphone.
I'm starting to fade. I'm not used to the microphone.
You know what? I'm gonna unplug it. I'm unplugging it, Mr. Decker. I'm sorry. No,
Sorry,
I'm
don't
unplugging
be
it.
sorry. It's not the wire, it's that big black, that box
Yeah.
that keeps getting me. Hold on a minute. Y'all want to move? Oh, we can't because it'll. See, that's where they should have let us go in. But
I thought you'd be rude. I was like, y'all want to
Oh,
go?
no.
Like,
no. Yeah, I just thought about it. I was gonna see if we could move, but then he'd have to move all that, so we can't. I wish they'd open that wall at least. We talked about that. I want to get back in this though. I want to get back in this. Hold up, we almost done this part, I think. Yeah, we almost got all that in us. And that's good. All right. So we almost got that knocked out. Let's work on some of this. Should I? I don't know. Let me see. Should I be nice? Maybe. Depends on how the response of the crowd. If y'all make me feel like sexual chocolate, then no. Be nice. Maybe.
hey, even if I say the wrong answer, I'm
Yeah,
gonna say
but
something.
that's what you're supposed to do.
I tried.
Correct. Wow, you're gonna remember it when you get shot
I
down.
know, right? Hey, you saw me today, CBC.
And you know it now, don't you? That's what you need. That's the best medicine in the world to cure lack of knowledge is to get it wrong and have somebody tell you, no, you're wrong. If I tell you you're right, all you do is go, I knew that.
So just for that.
Don't you think Mr. Decker had to go through a long period of no? Yeah. Probably more than y'all because I was trying to answer everything. I was on everything, trying my hardest. I remember the time one time just really, really got to me when I was in MA school and they told us to learn the muscles. So I was under the impression they had to learn them all. So that night I went home and learned all the muscles, stayed up all night, knew every single muscle. Next day I went to class ready for the test because that's what she told us the test was going to be on, all the muscles. Of course, nobody else studied the muscles, so you only had to know like 3 or 4. I was like, man, come on. She had only 3 to 4 that were with a line. I labeled that entire body. Well, you're just no. I follow what you said. You said learn the muscles. You didn't say learn 3 or 4 muscles. You said learn the muscles. I learned the muscles. And I tell you what, that paid off for me though. So when I came back to nursing school, guess what? I didn't have to learn again. The muscles, or any of the anatomy and physiology.
When I took anatomy at Rasmussen
Yeah.
on campus, they threw that skeleton all over the table in 2 different rooms and said name the bones.
They said what?
They said name the bones.
Excellent.
It was just little bones everywhere.
Excellent.
Terrible.
Excellent. That's the way. Excellent. That's a good school. I like that. All right, pay attention. Pay attention. What medication do they use as a last resort to treat schizophrenia? Bam! We ain't playing today, are we? All right, hold on now. Don't get too. What lab test is the most prevalent to check? No. Don't anybody else in this room answer this or attempt to answer this. Tamika Broxson. What lab test is essential for clozapine?
WBC.
So what is that included in? What lab test would that you just talked about you know today? CBC. 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 Huh? CBC. Does everybody understand that? What's the most important lab test for clozapine? What type of antipsychotic is clozapine? Excellent. Also known as atypical. Listen, you don't know how they're going to word the test question. They don't have to call it second generation. They can say the patient's taking an atypical. Do you understand that? They can say the patient's taking a first generation. They can say the patient's taking a traditional. They can say the patient's taking a neuroleptic. Huh? They can say any of those things. And they're still talking about the same thing. They can say that, can't they? Okay. You got a patient. Come on, put the potato chips down for a second. You got a patient in the ER that's complaining of intractable epistaxis. What does intractable mean? Upon assessment, you note petechiae and ecchymosis on the chest and the arms. What does that indicate? And he's otherwise well. I can't say how you can say that, but okay. Lab results are normal except the platelet count, which is 29,000. What order or medication order would you anticipate? Let me give you the choices. Who wants the choices? Huh? What condition, number one, does this sound like? Thrombocytopenic purpura, maybe? They even gave you a hint by telling you what lab was really low at the very end. Thrombocytopenic purpura. Doesn't that sound like that condition? Thrombocytopenic means what? Low platelets. What does the purpura part mean? You're going to see the bleeding in the skin. Didn't it describe the bleeding in the skin? Let's go back and say, what did it say was all over?
Petechiae.
Petechiae and ecchymosis, which is the same thing as what? Purpura. Petechiae is the smallest. What's the second smallest? Purpura. And what's the largest? But they all mean the same thing. They told you about their what count? Now, this is a high level answer. High level. I'm going to give you the choices. IV epoetin, IM phytonatoin, IV methylprednisolone, or IV immunoglobulin. What are we giving? We'd have to know what each of those do first, wouldn't we? The epoetin's going to replace what? Red blood cells. That's not our problem here, is it? The phytonatoin's going to replace what? The vitamin K. It's not a clotting factor problem. It's a platelet problem. Are you listening to me? IV methylprednisolone. What is that going to do? What is that? That's a corticosteroid. That's a corticosteroid. Okay? Or IV immunoglobulin. What is the IV immunoglobulin going to do? What is the IV immunoglobulin going to do? That'll stop the bleed, but that's second line. What should you give them first line? The steroid. The steroid. The steroid. You're going to give them the steroid. The otherwise healthy patient with intractable bleeding, with widespread bruising, petechiae, and low platelets, who does not have any other lab abnormalities, likely has immune thrombocytopenic purpura. The drug of choice for immune thrombocytopenic purpura is a corticosteroid such as IV methylprednisolone, which can help stop bleeding and help normalize platelet counts. IV immunoglobulin is the second line drug. It is sometimes administered together with methylprednisolone for severe bleeding, which the patient does not have. IM phytonatoin is used to treat warfarin overdose because it synthesizes what? Vitamin K, and is administered to neonates to prevent hemorrhage. Epoetin is used to treat anemia, not ITP. Okay? The patient may also receive a what transfusion if the platelets get too low? Platelet transfusion. Once it drops below at 25,000. Okay? It's at 29,000. Do we understand where we went wrong? Where did we go wrong? Let's read the question again. Okay? You got a patient complaining of what? Intractable epistaxis or nosebleed. So they got to bleed. Then we assess them and all we see are signs of what? Bleeding. But then it said he's otherwise well. So they can't find nothing else wrong except for signs of a what? And the only lab that's off is the what? So we're looking for a condition that affects the platelets. Are you listening to me? We're looking for a condition that affects the what? And in this case, it was an immune thrombocytopenic purpura. So your body is destroying the platelets. Your own body is destroying the what? Not a hard question. Okay? But it's a hard question when what? You don't know what the meds do. Okay? You don't know what the meds do. Okay? You got to know what epoetin does. What does it do? You got to know what phytonatoin does. What does that do? Vitamin K. You got to know what methylprednisolone is. What is that? Corticosteroid. You got to know what immunoglobulins do. Suppress the immune system. Do we understand that? You got to know, you got to know, you got to know. What do you got to know? All right, let's try this one. You got a patient diagnosed with type 2 diabetes mellitus. He's unable to control his blood glucose levels with diet and exercise. Which medication is first-line treatment? Metformin. Very good. I had 1. 2, you got it 2? I got 2. Anybody else knew that? Who knew that? Nobody knew that? Metformin is the initial drug of choice for recently diagnosed type 2 diabetes mellitus that is not controlled by diet and exercise. Glyburide, acarbose, and regular insulin are all used in the treatment of type 2 diabetes mellitus, but they are not the initial drug of choice. What is the initial drug of choice? And what is the advantage of metformin? What is the advantage of metformin? Look it up. What is the advantage of metformin over the other anti-diabetic drugs? That might be too vague. Ask it this. Does metformin cause hypoglycemia?
The first line medication affects more blood pressure. Blood glucose without significantly increasing the risk of hypoglycemia.
Did we hear that? What is the advantage of using what is the advantage of using metformin? Does everybody hear that? All the other anti-diabetic drugs, we got to worry about what? But what advantage do we get by using metformin? Sexual chocolate. What is the disadvantage of using metformin? What is the disadvantage of using metformin?
Because of vitamin D deficiency.
Vitamin B deficiency, but what else? Look up metformin. Very good. Say it again. Now put your phones down, put your pens down, put your computers down, and look up here. What will lactic acid do? What will lactic acid do? Affect the kidneys, and you'll go into acidosis. Do you understand that? Listen to what I'm teaching you. What am I teaching you? So you want to avoid other things that also produce lactic acid when you're taking metformin, right? What's a well-known thing that we use for diagnostic procedures that can increase the lactic acid levels? Contrast. So what's the rule for someone taking metformin? They need to stop it at least how long before a surgical procedure and how long after? 48 hours before, and they don't restart it until when? 48 hours after. Everybody got that? Who's got that? Now, look this up. Look this up. Matter of fact, no, look this up. What time is it? All right, we got time. Look up diabetic ketoacidosis versus hyperosmolar hyperglycemic non-ketoic state, or just HHS. Look up DKA versus HHS. DKA versus HHS. Who's got it?
DKA more common in type 1 diabetes.
Stop. That's the first teaching. DKA is more common in what type of diabetic? HHS is more common in what type of diabetic? How many H's are in HHS? That helps. Huh? DKA is more common in who? HHS is more common in who? Keep going.
Type 1 diabetics involves ketone production and metabolic acidosis, while HHS type 2 diabetes is characterized by severe hyperglycemia, dehydration without significant ketosis.
You want me to shorten that for you? You need that shortened because you need to remember this because that was on my NCLEX. Which one of the two is a metabolic disorder? Which of the two, the DKA or the HHS, is a metabolic disorder? Do we understand that? It's going to affect the pH. It's going to affect the pH. Do we understand that? They're both metabolic disorders, but that's an acid-base metabolic disorder. Do you understand that? Pay attention. Which one is going to send you into acidosis? Which is the only one with an A in it? Which one's going to send you into acidosis? Which type of diabetic is more prone to DKA? Why? Because they produce zero what? And you need insulin to break down what nutrient, what main nutrient that we learned about? Carbohydrates. And since the body can't use carbs for energy because there's no insulin to break it down, what does the body use instead? Fats. And what is the byproduct of fat metabolism? Ketones. And ketones are very what? Acidic. And that's where the acidosis comes from. Do we understand that? Sexual chocolate. Do we understand that? HHS is all about a hyperosmolar state. What is a hyperosmolar state? What does the word hyper mean? High. What do we measure most things in the body? Osmoles. What gives the solution the weight? Particles. So when you have an hyperosmolar state, what are they telling you? Too many particles in the blood. What do we know about a natural process that's going to happen when that takes place? Osmosis. And it's going to pull the water from where? The cells. So it's going to cause severe what? Dehydration. And with HHS, because it has two H's, the sugar ain't high, the sugar is double high. The sugar ain't high, the sugar is what? Because you're talking about a blood sugar greater than 500 or 600. With DKA, it's going to be 350. With HHS, the sugar's going to be what? High. Do we understand that? And that's going to contribute to that hyperosmolar state because the sugar is a particle. So the dehydration is going to be more severe because there's more particles. Does everybody understand that? So if you had two words to describe DKA, what would they be? Acidotic state. If you had two words to describe HHS, what would they be? Severe dehydration. If you had two words to describe DKA, what would they be? If you had two words to describe HHS, what would they be? Do we understand that? The treatment for both of them initially is the same. Fluids. Until you fix the disparity between the particles in the fluid, all the other things are only going to make it worse. Are you listening to me? The first thing you want to do is balance the particles to fluid. You know they're going to have more particles than fluid in both conditions. So what's the first thing you want to give? Fluids. And you want to give a safe fluid. Do we understand that? Are you listening to me? Is sodium bicarb a particle? Yes. Is insulin a particle? Is potassium a particle? Until you fix the fluid particle disruption, you don't want to give them other ones. You want to balance out the fluid, then give the insulin. Then give the potassium. Then give the bicarb. But if you give them before you fix the fluid imbalance, what's going to happen? You're going to make it worse. Are you listening to me? You got to rehydrate the cells before you can put anything in them. They pulled all the water out of the cells because of the hyperosmolar state. It pulls the water out of the cell. What happens to the cell? It shrinks and shrivels. What are you going to put in a shrinked and shriveled cell? So what's the first thing you need to do? Hydrate the cells. Are you listening to me? Let's talk about another problem. When you have a really high blood sugar, what's the renal threshold? What's the renal threshold for blood sugar? 180. What does that mean? What does that mean? What does it mean? Yeah, why is the sugar? Yeah, after 180, anything above that, what is the kidney going to do? Excrete it. Sugar is like sandpaper when it goes through the kidneys. Are you listening to me? Sugar is like what? So it destroys the nephrons. But that's not what we're talking about here. What has to push that sugar out of the body? Fluid. So the higher the sugar, the more what loss? Are you listening to me? That's called osmotic diuresis. When you see the patient, what are the P's? The P's. Polydipsia, polyuria, polyphagia. What do you think they mean by the polyuria? That's osmotic diuresis. The body's trying to do what? Get the sugar out. But what does it need to propel the sugar out? So pay attention to what I'm about to teach you. If you get a patient and you know they got an elevated blood sugar, is the go-to insulin? Not if they're dehydrated. Not if they're dehydrated. Good luck, Chuck. Good luck, Chuck. You need to assess that patient with that high sugar for what first? Dehydration. And if they're dehydrated, not only do they need to get that insulin, but you better be hanging some what? Or that insulin ain't gonna do no good. Are you listening to me? You want to do your job the right way? Stop giving insulin on sliding scale without checking for what? Stop running and getting insulin bottles every time somebody's sugar's high. If they can take PO, what's the first thing you should encourage them to do for the first hour? 6 to 8 glasses of water. Did you hear that? That's a protocol. Do you understand that that's a protocol? That's a standard? But we miss that. How many times do you see that happen? Because ain't nobody want to do the work. Most of the time the people's in the hospital, oh man, I can't run that in the same line. I had to put in another IV to do that. Do your job the way your job is supposed to be done. The next time you have a patient and that machine says high, it don't even give you a number, you better not run and go get that what? You need to be running to get orders for some what? Are you listening to me? Make it make sense. Make it make sense. If you can't make it make sense, then what does that mean? It doesn't make sense. What kind of reaction can a patient have from taking metronidazole? Metronidazole. We've accepted that as an antibiotic, right? They have been lactation them out, but something else. There's a couple others cause photosensitivity, but there's another one I'm looking for. I'll give you a hint. It's the same type of effect that an alcoholic may experience if they're on aversion therapy. That disulfiram reaction. When you're taking that med, what should you avoid? And things that contain alcohol. Do you understand that? What's the name of the med we're talking about? What kind of reaction are we talking about? Disulfiram. What kind of reaction are we talking about? What kind of reaction are we talking about? What med are we talking about? See, you don't want to do it. Sexual chocolate. They don't want to do it. Ain't he good? What reaction are we talking about? You don't even know what I'm talking about. You know what I mean? Left side. Right side over here whispering, telling ghost stories. Left side, they're using sign language. What drug are we talking about? What kind of reaction, serious reaction could the patient experience? So when you get a new order for metronidazole, what should be included in your teachings to that patient? Metronidazole can cause patients taking disulfiram to have a severe and unpleasant reaction that are similar to those that occur when the patient taking disulfiram ingests alcohol. Therefore, the provider should be notified and an alternative med should be discussed. So if you're already on disulfiram therapy, then you shouldn't even be taking what? All right, you're on your own. 36.
Man.
See, they already know I'm bluffing because they know I ain't going to be able to use the copy. Y'all need this. I'm going to ask one of the other teachers to loan me some copies until payday. Oh, I love this question. I love this question. Because this is going to show me if y'all paying attention. Who is it, me or you? This question will tell me. This question will tell me if the problem is me or you. Right here, right now. By how many people can answer this? It will tell me at one time, straight off the rip. You got a patient with asthma. He's being treated for an MI. They put him on a beta blocker. What kind of beta blocker can this patient get, but you still got to monitor it? One person. It's not me. Okay. Who answered it? They had a chance. Selective. What if it was metoprolol? What if it was metoprolol? What if it was metoprolol? Can we give that? Yes, we can. It's selective. What if it was propanolol?
No.
All right. Got that part right. It says cardioselective beta blockers can safely be used in patients with mild to moderate asthma, COPD, because the benefits outweigh the risk. Beta blockers are not absolutely contraindicated if adequate medication and respiratory support is available, and ideally if it's used in a hospital setting. Non-selective beta blockers should be avoided in patients with asthma. We got that? What else do we got to know about them beta blockers? What can they mask? What can they mask? Huh? Hypoglycemia. Very good. One. What's the other thing they can mask? We can't walk into the NCLEX not knowing what beta blockers can mask. That is a simple, basic beta blocker 101 question. That is a beta blocker 101 question. They can mask the signs of what, Shagarian? She got you halfway. Hypoglycemia. But what is the other very important thing they can mask? Look it up. Look it up. This is too important not to look up. They can mask the signs of hypoglycemia, but they can also mask the signs of what? Look it up. They can mask the signs of hypoglycemia, but what else can they mask? What does it say up there? Beta blockers can mask symptoms of what? Especially what? Sepsis. And elder patients. Don't you think we should know that? Yeah. Are you going to take care of some diabetics that are also being treated for sepsis? Should you know that? Hola, ¿cómo está? What's the number one reason for stopping treatment with beta blockers as well? Why do people stop taking their beta blocker? Why do people stop taking their beta blockers? Beta blocker 101. Beta blocker 101. What are the two things beta blockers mask? And now, what's the number one reason that most people stop taking their beta blocker? I'm not going to give you the hint. If I told you males, that's too good of a hint. Erectile dysfunction. Beta blockers cause what? The only one that plays exception to this rule is this one here. Well, you gotta wait on the machine, not me. Nebivolol. Nebivolol appears to be the only exception. Huh? It'll still make it Nebivolol. Stop trying to get the answer. Oh, this is a good question. This is a good question. This question here is different than the other question. Because this question right here will tell me, is it me or is it you? Oh, I did? You got a patient taking high doses of prednisone for RA. What is RA? Which adverse event is associated with high doses of prednisone? Select all that apply. So I'm going to say it, and you tell me whether or not it applies. We got that? COPD exacerbation. Can prednisone cause COPD exacerbations? No, it's actually pretty helpful if you can't, nothing else helps with respiratory conditions. Hyperglycemia. Will prednisone cause hyperglycemia?
Yes.
Will prednisone cause sepsis? Yay or nay? Go ahead, keep shaking your head. Keep shaking your heads. That's right. Don't know, Mr. Decker, don't try to look at me like that. She kept going, mm-hmm. It suppresses the what? What about psychosis? Huh? Yes. Short and long-term corticosteroid use is associated with mood disorders and psychosis, sepsis, venous thromboembolism, and hyperglycemia. Prednisone is used to treat COPD exacerbations, so it won't make it worse. We got that? Patients taking an SSRI. Patients taking an SSRI. What is the first line treatment for depression, first of all? SSRI. SSRI. What is the common side effect of this drug? That's the most common. What else? Decreased libido. Very good. 3 of y'all out of 24. What is my odds? 3 out of 24. What'd I get, like? Is that like 12, 13%? Oh, you got a patient that's got a full thickness burn. A full thickness burn. Which of the following fluids would be best to administer? You got a full thickness burn. Which of the following fluids would be the best to administer? 0.9 sodium chloride, 5% albumin, lactated ringer, or 5% dextrose in water? Beautiful. Why lactated ringer? Those electrolytes. Okay. And I think that's it. Help is help, but help is help. Okay? I think that's enough help. Okay? I think that's enough help. Is that enough help? 38, what?
30.
Y'all say y'all want 40? What would y'all do if I came out with that stack with that 120 on it? Oh, they're gonna send you a letter. Sorry, you did not complete the end of the capstone program. Read the fine print on the paperwork. The school has the right. The school has the right at any time while still enrolled. Oh my. It's too good to be true.
No.
All right, I work at this other school. Did I tell you about it? It's the school that I graduated from. So I know you're going to think I'm crazy when I tell you, but you have to understand I have a really good relationship with them. They basically let me do whatever I want to do. I can throw anybody out anytime I want. I can teach whenever I want. I can do whatever I want to do. I don't hardly ever throw anybody out. And if I throw them out, I let them right back in. But anyway, so the reason why I'm telling you that part is so you'll understand where I'm coming from when their money ain't right now. It ain't been right for a long while because they're trying to get accredited. They don't have financial aid. So I've been kind of letting them slide on my paychecks. They owe me like 14 paychecks. I just got a message that said, make sure you turn in your time because I'm about to pay you back all of it. That's going to be a fat check. I'm on salary. Every 2 weeks, I bring home 22 from them times 14. That's about $30,000. That's after taxes. No, I'm paying them. I'm gonna do the right thing. Pay them credit cards off. Get my floor fixed. And who said that? He's percentage of that. I'm gonna open up a bank account and start him a little. I'm gonna see if they got what y'all look. Let me teach y'all something. What y'all need to be looking out for. I don't know if you remember, but years ago they used to have what are called bonds. I think that's coming back. As soon as that comes back, you need to jump on it. You need to jump on them bonds, huh?
My bank did have. I did a CD for both of my kids when they were born.
Yeah. Yeah.
And my daughter's is like, she got hers in 09, but I started with 5,000.
Well, when I was a little kid, I bought one for like $50, and I had to wait. I think it was like 5 years, and then it became $150, 3 times the money. But I'm telling you, the bonds come back. You better jump on them. Our economy is gonna look. Our economy right now is like this, but eventually it's gonna go. Watch what I tell you. Our economy is about to go this way. Watch what I tell you. You better be looking into it. I'm looking into it. All right, listen. It's Friday. I didn't bring you a rose, but I'm gonna let you go to lunch early. Go ahead, take your lunch now. What? It's not enough to pay off the truck. I owe about $44,000 on that truck. Yeah, $44,000. That truck is expensive, man. They're expensive though. You bet. No, listen to me. Hold up. Listen. You can't go to lunch yet until you hear the story. My Camaro payment was only like $350, $360. I did not want a payment over like $400. I got talked into a payment on that truck. I'm paying about $730 a month. You do not want that kind of payment. I don't care. You don't want that kind of payment. Do you understand that? When you got them kind of payments and you working at a job that you unhappy with, you can't just leave it. When you got them kind of payments, you got to have that money in the bank on time every month when they go to pull it out. You need to think about them things before you get them payments. Can you afford it? Sure you can. But are you accounting for emergencies and other things that are going to happen? Because they're going to want their money regardless. Do you understand that? So don't overspend just because you can. Get in that little, you know what I mean, the little coffee cup car and call it a day. All right. Huh? Let me go ask something. Hold on before y'all go. Let me go ask. I'm gonna ask if y'all can take this test right now and go. Let me ask. I don't know. Let me ask.
I've been saying that since the beginning of summer. I can't wait till it's almost over. Good God. I can go pick up my baby from school now. Today, Kelsey, I'm talking about today. Kelsey, I did the 65. No, that was the old yesterday you made. Didn't it? Yeah. Yes, and we didn't have a chance for long. So we just had it. So you be surprised. I'm not, because I'm not married to kids. Not you there, that's another reason. That was your, there's no chance to be like that.
Y'all gonna study for this before that NCLEX?
Yeah.
Start time and all that? Y'all gonna let Mr. Decker know when you took the test?
Oh, yeah. I got your number.
Y'all gonna let Mr. Decker know?
We coming to your
I
house
will
this
if you don't
weekend
let me
for
know.
a
I'm
cookout.
gonna be hunting. I'm gonna be stalking.
You got no fun, I'm definitely gonna call.
Oh, yeah.
Okay. All right, let's take this test. Put everything away. I want it fair and square. And you can't leave because you got a grader.
Oh no.
Everybody's done, we later, and then you leave. Well, you're gonna swap them around anyway.
Oh my God.
Stay at your desk.
Right here.
You're done, stay at your desk, wait until everybody's done. And then we're gonna switch them around, put your names on them and the date.
We're gonna do it like that. About confidentiality.
That ain't no confidentiality. Oh, cause I got it on Saturday. Pass it down the line. I didn't give you enough. Get one for that stack right there. Put your names and your dates, please. First and last name. This is from Miss Coons. It's just proof that y'all did the boot camp. Did I put that thing there? Put that thing in. Thing for that. Who's not to number 15 yet? Y'all get to number 15, let me know. Those at number 15, stop. You're 15 or beyond, stop. Let them get to number 15. Let them get to number 10. Let me know when you're at number 10. Stop at 10.
No.
10. You already passed it. Just stop. I got a staff meeting at 1 o'clock. That's why I'm kind of trying to hurry it up. 'Cause Gotta make almost 12, but I'm eating lunch too. I don't want everybody getting hungry, so just don't look right. But you got it. All right, stop and exchange your paper with the person next to you, whatever you got All right, pay attention. Pay attention. Pay attention. Number one should be D. If you have a question why something should be something, ask me. Number two should be B. B as in boy. Which assessment is most consistent with disorganized schizophrenia? That would be social withdrawal and making up non-sensual words. Disorganized schizophrenia is characterized by social withdrawal and making up non-sensual words and weird speech. People with residual type schizophrenia have attentional deficits, sudden onset of stupor and becoming stuck until moved by another person, and this is called catatonic schizophrenia. Prominent paranoia, suspiciousness, mistrust, and hallucinations are characteristics of paranoid schizophrenia. We got that? Number three is C. Everybody good with that? Number four is D. Number five is B. Did we get that right, number five? We should have all got that right? Oh, how? Number six should be C. Did we get that right? Oh, we got to talk about that. Pay attention, pay attention. What? What? Number six is C. Oh, I thought we said we got it wrong. Everybody got it right? Who didn't get it right? All right, thanks for being honest. Primary nursing is when the nurse is at the bedside all the time. Primo means what? All the nurse is given by that care is given by that RN continuously. We got that? Team nursing is when everybody is assigned to the patient and the patient's needs. So everybody's centered on the patient. Functional nursing is when everybody has an individual task and they only focus on that individual task. It's just so that we can function. It's just good enough to let us what? But there ain't no teamwork involved. You're going to usually see that when you have a bunch of floaters or people called off. What are we going to do to get through the ship? Functional. We can't do team nursing because we ain't used to working together. Are you listening to? The problem with functional nursing is the focus gets lost off the patient because everybody's only focused on their individual what? Everybody got that? I'm not familiar with exemplary model of nursing. I think that's just a throw off. Team nursing is a system that distributes the care of a patient amongst a team that is all working together to provide for this person. This team consists of up to 4 to 6 members that has a team leader who gives jobs and instructions to the group. We good with the answer and the rationale? Number 7 should be C. Everybody get that?
Yeah.
Number 8 should be A. Number 9 should be A. Everybody good with that? Huh?
Is it, you said 8?
Number 9 should be A. Number 9?
Yes. I'm saying the Q because it's just saying.
The nurse is sitting with a family whose matriarch died within the last hour. The family is exhibiting which form of grief? And the answer should be acute because it just happened suddenly. Acute grief is the initial stage of grief that occurs soon after a death. This is a normal response to the loss of a loved one. Anticipatory grief occurs before a loved one has passed away. Got that? Number 10 should be A. You good with that? A. Number 11 should be C. What? What? I know, I'm giving you the answer. Write it down.
So we can switch back. Oh, no, I'm trying to.
Pay attention. Pay attention. I don't have time for people to sit for an hour and take this exam. I have a what? So I'm only making you go to number what? And then I'm being nice and giving you what?
Answers.
And then later on, you can look over the review. And if you got a question, you know my cell number. Number 12 is A. So, because what you should find, pay attention, is the farther I go through this test, the more things that we went over already.
What was 11? I don't know if you said that or not. C.
11 is C, 12 is A. 13 is A. 14 is C.
Wait, 13 is A?
Yeah.
13 is A. Mr. Pike was hiking last week and he has come to the ER with a fever, muscle ache, and chills. He has been clinically diagnosed with Rocky Mountain spotted fever and is prescribed doxycycline. Mr. Pike states my blood test didn't prove I have Rocky Mountain spotted fever. I don't want to take the antibiotic unless I know for sure I have it. Which response by the nurse is most appropriate? And it says, RMSF can be really deadly. You should take the medication. That is the correct answer. Okay? You are entitled to refuse treatment. However, untreated RMSF has a 20% mortality rate. With treatment, the mortality rate is only 5%. The nurse should educate the patient both about any risk from taking the antibiotics and the risk of not treating the disease, and then respect the patient's decision. But initially, we need to tell them that RMSF can be really what? And that you should do what? And then if they refuse again, then we should what? Accept it. Are you listening to me? Number 14 should be C. Number 15 should be A. The provider tells the nurse that the goal of therapy for a patient with CHF and acute pulmonary edema is preload reduction. To accomplish this, the nurse anticipates administering which of the following medications? Sublingual nitro. Nitro is going to do what to the blood vessels? What is that going to mean for the speed of the blood returning back to the heart? Slower. So how will it fill in the chambers then? Slower. So if it doesn't fill as much as it usually does, will the myocyte stretch as much as it normally does? No. So if the myocyte doesn't stretch as much as it normally does, will it contract as forceful as it normally does? So we reduce the preload. We understand that. Number 15 is A. Do we understand that one? Dantrolene is a what? Number 16 is B. Does everybody understand that? Number 17 is A. Does everybody understand that? 18 is C. 19 is C. Number 20 is B. 21 is B. 22 is B. 23 is C. 24 is C. 25 is A. 26 is A, B, and C. 27 is A. 28 is A. 29 is C. We already went over all of these. And 30 is C. I think what I'm going to do, I didn't know how interested you would be in that, but it seems like you're quite interested in this. So I'm going to email you the whole 120 question test with the rationales. How about that? Yeah, do me a favor. Somebody send me an email right now and remind me. Just send me an email and say, hey, send the test. Who's gonna send me that email? I don't want 99 emails here.
Who nominated my class?
Oh, I need them papers back.
You what?
I need the papers back.
Okay.
Come on.
I hate
Come on, give me your test. God bless you guys.
See you at Grand.
Yeah, that's the snacker. You gonna be my son? You know I will. Please, No, so we gonna be eating now.
You should think about teaching. Okay?
I should think about sitting in on the teacher, huh?
What do you say?
I should think about sitting in on another teacher. Me, I'm just being funny.
Stop being
You
funny.
think-
You vindicated yourself today. I'll probably do it. Friday.
Yeah, it's that way. I sent the address.
Okay, they trying to keep us here.
Bye, Mr. Decker.
You should at least get the 80 or the 90. And you don't even need it.
That's what I'm saying about. I did the 4, so that's a 90, right?
I lay
I thought you said anyone after.
not anyone after you got to get the majority after.
So I didn't do one. How many more?
Why you worried like it ain't
I
gonna
want
fit?
to take my time to pad to read
But that's
over
not
information. I
That's
don't
not
want to
gonna
rush it.
affect you. You still, if I give you an 80, it's not gonna drop your score to fail it.
No, it ain't, but still I was looking for a 90.
Okay, everything is up.
You got most of them done.
But I need to learn. This
Yeah, I
is my
agree.
last one. I
That's
have
why
to
when
read
you
about
worry
it.
about the grade, don't worry about the number.
Yeah.
Okay, I'll try to get you a 90. Okay?
Okay,
do
because that's
my
what I thought you said.
I was trying to
the
get a
other day.
You may not be procrastinating. Get that.
No, I'm not
I
getting
need 2. I need an 8.
All right.
That's my.
I did everything except for the green light.
Did you get a 90?
That ain't an 8.
That is an 80.
I don't know.
Who
I
cares
was
about
wondering
an
who
80?
was taking y'all pictures.
No, I'm finna. Did you finna take me and Mr. Jacob picture? I want it outside. I want the picture out the door.
That's what I
Here,
read
I
on
gotta
the
go
paper.
put these up.
Okay, come on, meet me out the door.
All right.
Oh, Mr. Jacob,
Probably all get 90.
Okay, so that's why I need to learn that. You know, I have to read about it. I'm not ridiculous. I'm just saying. I don't know what.
Get that grade.
Thanks for letting us come, even though like we're not graduating yet, but that was great.
trade that we need.
wore these chairs, they're not supposed to be here. They were just in their boot camp, and today was the ABN last day, so they're all excited.
What do they call it? What?
The professional nursing is ABN, so it's like a associate student.
Right.
Yeah. So this is one of our classrooms. We do have 24 max students to a class, so it's definitely not huge. You get one-on-one at one time, ask more questions, and the opportunity. You kind of choose self-sit in the class.
Yes, for sure.
Yeah, what row?
I'm somewhere in the middle.
Middle, that's my most popular.